Just testing.
Yeah, you have time.
I'll message it.
So I'm not gonna take long anyway.
Oh yeah, how come it's so short?
Because, well, one, I don't want to be going through every single individual muscle and making.
Oh, you'll just be like, learn this.
No, I'm gonna be like, this is actually what's gonna be on the exam.
Oh.
I'm going for the best cash money. Let's start sticking into it, just to make sure that it's working or not.
Yeah, you're not
Testing. Guys, can we quiet down a bit? You're testing the mic.
You think that's pretty?
I reckon that's working. All right, so mic is working fine. Please sit at a proper seat, not on the staircase. Right, are we good to start? Okay, cool. Right, hi everyone. Sorry for the delay. Hospital finished late. That's 1, 2. There was someone in front of me who was trying to reverse park and failed 5 times and took 5 minutes to actually park into it. So I missed my parking spot. But anyway, I'm here now. Right, so my neck hurts. I had a long day. I'm gonna be covering upper limb anatomy today. Upper limb, as far as the bio goes, it's actually probably not the highest skill stuff, and it's definitely not anyone's favorite. But that being said, there will be some questions on it, so it's kind of worthwhile going through it. So I plan to make, basically this is different from my usual Biceps. Oh yeah, by the way, for those who don't know me, I'm Zhongji, I'm one of the 30 years here. So pretty sure everyone knows me. But anyway, so the way this presentation is gonna work is gonna be a little different from my usual presentation. I'm gonna be like basically telling you, all right, this is like what's gonna be on the exam. This is the kind of thing you can probably read on your own time. It's just like a summary table of stuff. You can read it in your own time. And if anything doesn't make sense, you can always go to read my anatomy mega document from last year. Last year, Dongju did a pretty okay job at making it. So, right. So let's get it working. That's great. Right. So I like to highlight things that are actually like really high examinable marks or something that's like out of unusual because it stands out. Cool. So what we're going to be doing is we're going to cover briefly the embryology of the upper limb. That's my phone. That shouldn't be going off, but it went off anyway. All right, sounds. And then we're going to be covering the gross anatomy of various areas that's under upper limb, and then we're going to be covering the neurovasculature and pathologies here and there. And for those of you who are going to be watching this stream, like, I don't know, 2 days before the bio or something during your swap back, just skip straight to the end of the slide. There are summary slides, basically, that summarizes the whole presentation. Cool. Right. So embryology. Not the highest deal compared to GIT embryology or cardio embryology kind of things. So we'll just briefly cover it. You may or may not recall this, but really quickly, upper limb embryology starts in day 24 of gestation, a little bit faster than the lower limb. And you get a limb bud that forms from the mesoderm and the ectoderm. And you get the limb differentiation. So you don't have humerus, radius, ulna, and all the carpal bones from the beginning. You only have the humerus, and it stretches out. And when it's done making the humerus, then it starts making the radius and ulna. And then when that's done making it, then it starts making the carpal bones, right? You don't have all of that in compact, like in a like condensed into one limb bud, and then you just get stressed out. No. You just form the humerus first in sequences. Right? So you can already see that if something goes wrong during this 5 to 8 week periods, then you're gonna have someone who's gonna be missing like complete missing of radius and ulna and carpal bones, but still has the complete humerus or something like that. So embryology, this is like as simple as it's gonna get as far as the upper limb goes, and also this applies to the lower limb as well. But development of limb basically occurs in 3 axes. You have the proximal distal axis, that's you forming humerus, then the radius and ulna, then the carpal bones and the metacarpal bones and the fundus axis, right? That's driven by what you call apical ectodermal ridge, right? That's all you have to know about it. Like there's also FGF playing in it, which is like fibroblast growing factor. Basically, apical ectodermal ridge is governed by the gene called Hox genes. It basically governs the proximal to distal axis formation. But what it also does is it creates the anterior posterior axis. So in embryology, anterior posterior axis, you may recall, is a little bit different from your anatomical sense of anterior posterior, which is basically the same as dorsal and ventral in adults. But in embryology, anterior posterior means basically anterior to your thumb side and posterior to your pinky finger side, right? So you will probably vaguely remember this name, sonic the hedgehog morphogen, right? Sonic hedgehog morphogen, that's the one that basically is induces the zonal polarizing activity, and that creates the anterior to posterior, so your thumb to pinky finger differentiation. And the last axis that that creates the upper limb is basically the dorsal and ventral axis. All you have to know is basically what's gonna be the palm side and what's gonna be the dorsal side. And all you have to know is that it's mediated by the WNT7A signaling, and the minor point underneath you may read it if you have time. But that's really like quickly embryology in a nutshell. And these are basically pathology like limb pathology and malia. So the complete limb abnormalities, they were associated with thalidomide, which is one of the tetragenic drugs. They went up to the phase 4 trial, and then they realized, hang on, the baby's inflection right. So they went back to phase 2, and it's, oh, crap, we missed off, right? So it's taken off the drug list now. But anyway, so it's really rare to see those now. And then you have the digit abnormalities, which you can read in your own time. But the name basically says it. So polydactyly, poly means multiple, dactyly means digits. So you have extra digit, which is relatively common, and also all the others. But this is all really relatively low-yield stuff. I just summarized it again in the next slide if you want to have a read at it. But let's get to more anatomy actual part of it, which is probably going to be examined. So that was embryology. Any questions? No? Great. Cool. That went too fast? No? Okay. Well, I mean, it's low-yield. Thoracic anatomy. So I'm not going to be reading every single bones. Like here's the picture of clavicle, here's the scapula. I'm going to be only talking about what's going to be on your via, not really the gross anatomy again, because that's going to take me forever to cover, and also it's going to bore everyone to death. So scapula, just know the anatomy of it. Clavicle, know the anatomy of it, but there's also that everyone probably vaguely remembers this again. So clavicle, it fractures most commonly when it changes from convex to concave shape. And this is described as either the lateral 1/3 or the medial 2/3 of the point. So when this fracture does happen, it pulls the lateral 1/3 inferiorly because the weight of upper limb is pulling down on it, and also medially because your pectoralis muscles is still intact, so it pulls it up, adducts it. And you also have the medial 2/3 that's going up because your sternocleidomastoid muscle, one of your major neck muscles, is pulling it up superiorly. So when this fracture does happen, it basically endangers everything that's underneath it. Hello. So it basically endangers the subclavian arteries and veins, and also the division part of the brachial plexus, and also the supraclavicular nerves, which you don't really have to know about, but I just put it in there for the sake of completion. Cool. Muscles of pectoral and shoulder region. Right, so unlike most of the muscles in the axial upper limb, the thoracic muscles, they are typically not really examined. The ones, I've highlighted the ones that are probably going to be relevant. So definitely your rotator cuff muscles, they can definitely be examined. Serratus anterior, because there's a pathology associated with it, which everyone has to remember. And also the pectoralis major and minor muscles, because they serve insignificant landmarks in the shoulder kind of pectoral area. And also the deltoid. Right, let's look a little bit more detail. So I'm not gonna go through every single attachments of the muscles, that's gonna be boring. no one's gonna be listening to me. Everyone's gonna be on, I don't know, Facebook or whatever you want to be on. But let's just go through the higher yield stuff. Rotator cuff muscles, right? Yes. Yeah. One more.
You write this factor for the lateral superior lateral area. So which one?
Oh, what? Sorry. So where's my mouse? There. So, can you see my mouse? No. Right. So the medial one-third, the arrow is pointing down, right? So the, sorry, lateral one-third. Sorry, the lateral one-third is getting pulled down because your weight of upper limb is pulling it down, and also it's probably getting pulled medially as well. Oh shit, okay, sorry, that's the mistake on the slides. I'll fix that, sorry about that. Someone remind me to fix that. Yeah, ignore what I just said on the slides, listen to what I'm saying right now. Okay, I'll clarify again. So
I'll keep going.
Oh, we can just fix it?
Oh no, just keep going.
Oh, okay. The lateral one-third, my mistake, sorry. Whatever is closer to the upper limb, so your lateral one-third gets pulled down inferiorly and also medially. But the medial two-third is gonna get pulled up superiorly because your sternocleidomastoid muscle is pulling on it. I think the next, what are you doing?
Sorry, because some people want to see the full thing instead of presenting it. Extend.
All right, in the meantime, any questions so far? No, cool.
I don't know if that'll work, but go for it.
Well, now you just made it for everyone in here as well.
Shit.
Well, I guess the people who are watching it have to suck it up. Those of you who are watching the live stream, unfortunately, we are not good with technology and you're going to have to suck it up. Cool. So, let's get back to it. Rotator cuff muscles. So really, like the major one that's usually discussed is the supraspinatus muscle, because it's unlike the other rotator cuff muscles, which literally rotates the humerus. This one also has a role in induction of the shoulder abduction. So first 30 degrees of it, and so therefore it has a lot of strain on it, and therefore it is most commonly injured, and therefore it's important to know where it is. Right. So you probably recall this now. So the first 30 degrees of abduction is initiated by the supraspinatus, and then the remainder of it is done by your deltoid muscle. So if someone has a ruptured supraspinatus tendon, then they can't initiate abduction. But once you actually passively abduct for them, past the first 30 degrees, they can abduct fine because the deltoid is still intact. Infraspinatus and teres minor, they quite literally next to each other, as you can see on the diagram as well. Their roles are pretty much the same. Their nerve supply is a little bit different, but that's about it. And subscapularis, I'll just point it out, that unlike the other three rotator cuff muscles, which are attached to the posterior surface of the scapula, subscapularis muscle actually originates from the anterior surface of the scapula, which is the subscapular fossa. So it also has a different insertion compared to the remaining three rotator cuff muscles. All the rotator cuff muscles, except for subscapularis, attaches to the greater tubercle of humerus, whereas the subscapularis is the only one that attaches to the lesser tubercle of the humerus. Also know their roles pretty well. You can read that in your own time. And there's also something called the painful arc. So your rotator cuff muscles, tendons, I guess, they pass through the subacromial space. But also in the subacromial space, there's a bursa. So if you have an inflammation of the bursa, so i.e., in other words, your subacromial bursitis, you get something called the painful arc, which is basically you're fine for the first 60 degrees, and then it hurts, and it gets fine again. It just happens because of the angle of the rotator cuff tendons. Cool. And then we get to the axilla. So this is usually the area that's kind of like people look at it and it's like, yeah, all right, it's basically your armpit, kind of leave it there and then don't really look at it. It's actually kind of important in second year and third year, of course, as well for the VIA. So it's it's probably okay to learn it. So it's basically a four-sided pyramid, but not really a pyramid because it doesn't have a pointy end. It has a flat apex. And what's important really is about it. What's really important about it is basically every wall except for the medial wall has a lymph node, axillary lymph node group that's associated with it. And this is important, like the way they drain, because it's like metastatic breast cancer is a thing. It's a very common question to be there. And metastatic breast cancer, unfortunately, most commonly tends to happen in the outer upper quadrant, which is drained by the axillary lymph nodes directly. So let's briefly go through it. So the anterior wall, so your pectoralis muscle here, that's literally like lined by your pectoralis major and minor muscles. And not so surprisingly, the lymph node group associated with the anterior wall is called the pectoral lymph nodes, right? And they are the main draining lymph nodes of the upper outer quadrant of breast. So if you get a breast cancer, that's probably the first lymph node that's going to go into it. You also have the lateral wall on the lateral side of your body. That's where your upper limb is. That's where your humerus is. So that's where your lateral lymph nodes are at as well. It's lined by your humerus. Because it's lined by your humerus, it's near the humerus, it drains everything from the upper limb pretty much. Posterior, well, what's on your posterior side, opposite to the pectoralis muscle, your scapula, and also a whole bunch of other things that's not less important. And because it's on the posterior wall, your lymph node groups are posterior lymph nodes and so on. Right, medial wall is the serratus anterior muscle in the thoracic wall. So in other words, your rib cage and all the respiratory muscles. It doesn't have a lymph node group associated with it, unfortunately. Apex, it's the lateral border of the first rib and also the clavicle as well. And because it's on top of everything, it drains from all the other axillary lymph node groups. And the last one is at the base. That's where your armpit skin is at, and that's where your central lymph node groups are at. And that they basically drain from all the other lymph nodes as well, except for the apical one, because apical's on top of everything, so no one gets to tell it what to do. Right, what's the contents of axillary artery and vein, obviously, and also the axillary lymph nodes we just went through, and also the cords and the branches of the brachial plexus. You can find them within the axilla. Cool. Spaces of thorax, vaguely remember them: quadrilateral space, triangular space, and triangular interval. Just know that quadrilateral space has the axillary nerve and the posterior circumflex humeral artery, which are most commonly damaged when you have a surgical neck of humerus fracture. Right, and also the triangular interval, that's basically the gateway for the radial nerve and also the profundus brachii artery to go into the upper limb. Triangular space, not really that important, but it exists. It's a thing. Cool, so that's like the boring part, the thoracic part there, where it's like kind of wishy-washy and not really systematic. So any questions at this point? No? Okay, good. So we're actually gonna go into the arms now. So the way to learn the actual upper limb anatomy is basically you learn it by the compartments. You have the anterior compartment, you have the posterior compartment of the arm, you have the anterior compartment of the forearm, you have the posterior compartment of the forearm, and also you have the hand. Right, so it's the reason why you learn it in compartments is because each compartment has a general rule to be followed. But as far as the upper limb goes, let's start with the bones. So here's a nice picture of humerus. If you want to learn the landmarks, please feel free to do so. But what's probably gonna be actually on the exam is gonna be like in the format of like, if you fracture this part of humerus, what's gonna be damaged or what sign are you going to have? That's the kind of exam questions that you're probably looking at as far as the bio goes. So three different, well, four technically, but really three main fractures of the humerus. Surgical neck of the humerus fracture is the most common one in elderly. It's most commonly fractured, hence the name surgical, because the surgeons are working on it all the time. So as I said before, this is near where the quadrilateral space is, where the axillary nerve and the posterior circumflex humeral artery is running at. So if you have a transverse fracture across the surgical neck of humerus, what happens is that you get an axillary nerve damage, which innervates the deltoid and a couple of other muscles, but really mainly the deltoid is the one you're concerned about, and you get a paralysis of the deltoid. And the consequence is that one, you cannot abduct further beyond 30 degrees because remember the first 30 degrees done by your supraspinatus muscle. And also you have, but the remainder is done by the deltoid muscle. And also you have a sensory loss over the regimental patch area, which is just directly over the deltoid muscle. Right, so mid-shaft of humerus, it affects a different nerve, it affects the radial nerve, and it also affects the profundus brachial artery, but it doesn't really, no one cares. Radial nerve, so if you have a radial nerve injury, you're gonna present with wrist drop because you lose all of your extensors in the humerus. I'll go through it again, like there's a lot of overlapping in this presentation as well. Medial supracondylar ridge of humerus, this is like not something that's brought up every now and then, like not really brought up, but basically, this is where median nerve is like running right past it. So if this is another space other than the carpal tunnel where you can damage the median nerve. And lastly, the medial epicondyle fracture of the humerus. Your ulnar nerve runs directly posterior to the medial epicondyle. So if you damage that, you lose your ulnar nerve and then you present with ulnar claw. Right, as far as the dislocations go, there's only one that we really have to worry about. Is the fact that humerus is most likely to dislocate anterior inferiorly rather than posteriorly because the scapula is really steady in the posterior side, so it's very unlikely for you to get a posterior dislocation. However, anteriorly, there's only like muscles and skin, so there's not really, it's like free space, so you just dislocate that way. And of course, if you dislocate that way, then you basically endanger everything in the axillary again, so your axillary nerve once again, and also the posterior circumflex humeral artery. Cool. Am I going too fast? No, cool. Hopefully like 90% of the things that I'm talking about right now is like, oh yeah, I remember that from last year, vaguely kind of thing, and nothing new. Muscles of anterior arm, there's no point in me like running through, oh, this is like the proximal attachment, this is the distal attachment of this muscle, it does this. Like, I just made it a nice summary table for you if you want to have a look at it, and I've also highlighted what's probably gonna be more relevant. So, biceps brachii, its attachment is actually like probably a little bit worthwhile, which one's long head and which one's short head. I believe that was one of the exam questions for me. So know where the long head and the short head attachments are and how to differentiate them, and also the insertion. But general rules of anterior arm, basically all of them are innervated by the musculocutaneous nerve. So that's easy, that makes the memorization easy. And also because it's in the anterior arm, when they contract, it's gonna pull it up, so it's going to be associated with the flexion of forearm. Supination of forearm is probably usually done by biceps brachii. But anyway, let's see. Brachialis, unlike the biceps brachii muscle, which I'm going to talk a little bit more about on the next slide, brachialis muscle is the, as you can see on the diagram, it's the smaller muscle near the elbow. Unlike the biceps brachii, which attaches to the radial tuberosity, which radius, by the way, moves depending on whether your arm supinated or pronated. Brachialis attaches to the ulnar tuberosity, so it's on the ulna, and your ulna never moves regardless of whether you're supinated or pronated. So its strength of flexion is independent of the elbow position. Right. However, that being said, biceps brachii muscle attaches to the radius, which basically wraps around the ulna if you pronate, and therefore its strength is actually highly dependent on its position, on the position of your forearm. And unlike the contralateral relief, it's not the most powerful flexor, but it's actually the most powerful supinator of the forearm. And it creates, basically biceps brachii creates the maximum force when your elbow is flexed to 90 degrees and your forearm is in full supination, not pronation, supination. You actually lose most of your biceps brachii strength if you pronate your forearm while you're flexed. Right, and also the minimum flex force, you can read that in your own time. And there's a pathology associated with it. So, Popeye sign. Basically, your biceps brachii tendon, your distal tendon has been disconnected. So whenever you try to contract, your biceps just gets pulled up all the way up here. And then you get a Popeye sign, which is basically your biceps muscles just clumping up in the middle of your arm. Looks nasty. Cool. That's biceps. Landmark, cubital fossa. It's on the anterior side, so I might as well talk about it now. Know the borders. So if you went to my Vespa last year on upper limb, you may recall me jumping up and down the table, emphasizing this point. I'm not going to do that again this year. I'm too old for that. Medial border, but I'll emphasize it again for you guys. Medial border is lined by the lateral border of the pronated teres muscle, whereas the lateral border is lined by the medial border of the brachioradialis. So in other words, your cubital fossa doesn't encompass the muscles themselves. Right, and the superior border is just the imaginary line between the two epicondyles of the humerus. And the contents, median nerve, definitely. Radial nerve, debatable because it's kind of like on the edge of it. So some people say it's in the cubital fossa, other people say it's outside the cubital fossa. So I just put it there, and then it's like bracket debatable. And also, most importantly, your median cubital vein, which is where most of you will be doing your venipunctures next year when you're in third year. Cool. That's about it for cubital fossa, not much significance. So that's the anterior compartment. Posterior compartment, it's really just the triceps brachii muscle. Cool. Anything, arm, and also the forearm, anything that's posterior, it's going to be innervated by the radial nerve. Right? No exceptions, radial nerve. Cool. So its actions, extends, yeah, cool, all right, right? Nothing else really significant. They can't really examine you on the triceps brachii muscle attachments because it's like somewhere along the humerus is like the accurate answer actually. So just know that if it's posterior, it's gonna be innervated by the radial nerve. And if you lose your radial nerve, therefore, you're gonna lose these muscles. Cool. So that's the arm. Now we're gonna move on to the forearm. Hopefully I'm going at an okay speed, enough to like not too fast, but not too slow to bore everyone to death. Forearm, let's talk about bones first. So two fractures that you kind of have to know about is Colles fracture and the Smith fracture. You may recall the names. Colles fracture, so first fallen outstretched hand. And this one is the distal dislocation, sorry. This occurs when you have a transverse fracture of the distal radius, and that results in a posterior dislocation of the displacement of the distal radius. And it basically results in Dana-Fork deformity, where your hand kind of looks like a Dana-Fork. And the opposite of Colles fracture, I guess, is the Smith fracture, where it occurs instead of outstretched hand. If you fall in your flexed hand, it's going to dislocate the distal radius anteriorly. And that's all there is to it. So know which one's which, don't mix them up. Right, and then we'll get to the anterior forearm muscles. So general rule, the common attachment for the anterior forearm muscles is the common flexor tendon, which is attached to the medial condyle. So anything that's flexing, it's probably attached to the medial epicondyle. Of course, that doesn't really apply to the deep muscles. This is like the general rule, except for like special considerations. All right, so its main action is flexes. It's on the anterior side, so it flexes towards you. And everything except for two muscles, well, technically 1.5 muscles in the anterior forearm are innervated by the median nerve. So you don't have to memorize every single muscle. You just have to know where it is, and you can probably work out what nerve is innervating and what nerve is innervating the muscle. So the two exceptions are flexor carpi ulnaris. That's probably easy to remember because it has the ulnaris in its name, and also the medial half of the flexor digitorum profundus muscle, which is one of the deep muscles of your forearm, if you recall, and that is also innervated by the ulnar nerve. Right, there's a better, nicer diagram of the flexor digitorum profundus. Here's a whole list of things. Asterexis, it's like, I put the asterexis next to the things that are like, yeah, for the sake of remembering, this is true, but if you go deep into it, this is technically not true. I put up the explanation in the presented slides, I think, so have a look at them later. Cool, so, but anyway, re-emphasizing once again, everything is basically innervated by the median nerve if it's in the anterior forearm, except for the flexor carpi ulnaris and the median half of the flexor digitorum profundus. Cool. I'm rapidly declining in health. Well, let's move on. Superficialis versus profundus muscle. So both are kind of like flexors of your 4 digits, except for your thumb special, so you get a separate set of muscles. But noticeable difference. So flexor digitorum superficialis actually only attaches to your proximal phalanges, not the distal phalanges, and therefore it has no action on the distal phalanges, right? If it's bending your distal interphalangeal joint, then that's done by your flexor digitorum profundus muscle only, not the superficialis muscle. Cool. That's the anterior compartment. Now the posterior compartment. The general rule, once again, if it's in the posterior compartment, I'll emphasize it again. If it's in posterior, it's innervated by the radial nerve, and it's going to extend stuff, right? So here's a whole list of disgusting list of muscles that you probably don't have to know about. The emphasis I've made very clearly, one, brachioradialis muscle. So this is the only paradoxical forearm muscle, I suppose. It's paradoxical because you may recall, it's in the posterior compartment. It's innervated by the radial nerve, just like the remainder of the posterior compartment muscles. But what it actually does is it weakly flexes the elbow instead of extending it. Yes?
That's like posterior.
No, this is the posterior muscle, brachioradialis. Oh, for God's sake, don't you? Sorry, this is, yeah, the title's supposed to say muscles of posterior forearm. I'll fix that. I'll send the fixed slides to Will and he can probably upload it. Cool, thank you for pointing that out. Okay. Anyway, so this is the posterior forearm muscles, clarification. But brachioradialis, despite being a posterior forearm muscle, it still acts like an anterior muscle. That's like the weird part of it. That's why it's paradoxical. The remainder, like everything attaches to the common extensor tendon, which is on your lateral epicondyle, as opposed to your common flexor tendon, which is on your medial epicondyle. And everything's innervated by the radial nerve or some sort of branches of radial nerve. It extends stuff, right? And then there's like those three muscles at the bottom of the table I've highlighted. They are border of the anatomical snuff box. I'll go through it in detail later, but that's all there is to it. Please don't learn every single origins and insertions of all the muscles here. It's complete waste of time. You're better off learning DNA stuff from the first year of first semester, seriously. Don't. In other words, don't. Cool. Elbow pathologies. There are 4 elbows that you should know about. Golfer's elbow is so if you golf, you bend your arm, i.e. you flex your forearm, and that's got to do with flexion, which you probably remember, hopefully, because it was 3 slides ago. It's where the flexor muscles are at, which attaches to the medial epicondyle, so you get the medial epicondylitis. Right, and therefore you get pain on wrist flexion. You have the tennis elbow. Imagine doing a backhand of the tennis. You get the common extensor tendon inflammation, so you get pain on the extension of the elbows. You also have the student's elbow. You have the olecranon bursitis and nursemaid's elbow, which is basically nursemaids used to pull babies on one arm. Hopefully they don't do that anymore, but they dislocate the radius from the annular ligament, which is basically something that's keeping your radius and ulna together. And the way to fix it actually is basically just ask the baby you just make the baby supinate again, and then just like shove it back in. The more you know. Cool. Carpal tunnel. Right. You don't necessarily have to know the boundaries. Just know that flexor retinaculum is the upper boundary, or I should say superior or anterior, more superficial boundary of the carpal tunnel, and know the contents of the carpal tunnel. So remember that there are 10 structures within it. 9 of them are tendons, and 1 really important, so the median nerve. The 9 tendons, your flexor digitorum superficialis and the profundus tendons, and also the flexor pollicis longus tendon. Cool. Yeah, if you have an inflammation, you're gonna compress in your median nerve, and that's gonna give you carpal tunnel syndrome. It's gonna give you numbness over your lateral 3.5 digits. Cool. I'll go through it in more detail later. And next to the carpal tunnel is your friendly neighbor, Guyon's canal. That's where your ulnar artery and ulnar nerve enter the hand. So please do remember that ulnar nerve and the arteries do not go through the carpal tunnel. That's all I wanted to highlight about it. Cool. That's the upper limb. Hand now. Don't worry, the presentation's not coming to an end anytime soon. We have pathologies in the end, which is big money, which is why I'm going fast here. 8 carpal bones. Everyone knows the mnemonics. Please don't just remember the mnemonics, but actually remember the names of the bones as well. Don't just be sitting in the exam room like I did 2 years ago now. In the room, it's like some lovers try positions that they cannot handle. C. Okay, so what's C? I know it starts with the C, but what's actually C? I was sitting in the exam room like that, and it wasn't actually a short answer question. Anyway, I remembered in the end. Happy end. Right, and then you have the 5 metacarpal bones and 11 pathologies. Cool. Something to be highlighted. So, your radius and ulna. Radius is the only bone, not ulna. Radius is the only bone that directly articulates with your carpal bones. Ulna does not do this. Between the ulna and the carpal bones, you have triangular fiber cartilage complex. It's basically filling up the space between the carpal bones and the ulna. So no direct articulation between the carpal bones and the ulna, but direct articulation between the radius and the carpal bones. Cool. The only fracture, two fractures technically, that you have to know about, scaphoid fractures. Everyone remembers it. There's a retrograde arterial supply to the head of the scaphoid. So it happens. It often happens after a push, fallen outstretched hand, just like your Colles fracture, and it causes the avascular necrosis of the scaphoid. There you go, buzzword for next year, for the exams. And it takes up to 10 days for this to appear on the X-ray. So if your exam question asks, hey, this guy fell on the ground, we just took an X-ray right away, he looks fine, what do? Please do not pick the option of discharge him and send him away. We need him to come back in 10 days and take another X-ray. And you also have something called buxer fracture. So buxers, like the fist, are the box. But basically, if you basically get a fracture while you're in a fit, you're making a fist, then you get a fracture of the fifth metacarpal, and that's called the buxer fracture. Intrinsic muscles of the hand. So unlike your anterior forearm muscles, which was mainly innervated by the median nerve, with two exceptions, innervated by the ulnar nerve, intrinsic hand muscles are mainly innervated by the ulnar nerve, with 5 exceptions of median nerve innervations. So those are your thenar muscles, which makes sense because it's closer to the median nerve than the ulnar nerve. And also the 2 lateral lumbrical muscles. That's all you have to know about it. Intrinsic hand muscles, they were kind of boring. You don't really have to know about them. But in case you wanted to learn about them, there's like a whole table I made for you guys in terms of like nerves and the actions. No one's probably gonna read it, but I made it anyway. As far as the actions go, actually, I'll just quickly highlight the palmar interossei and the dorsal interossei muscles. So the mnemonic is PED and DEB. So PED, the palmar interossei muscles help adduct the fingers, whereas the dorsal interossei muscles help to abduct the fingers. Please don't do that in my presentation. And one more thing, right? So dorsal interossei muscles, they're actually on the posterior surface of the upper limb, technically, because they're dorsal, but they're not innervated by the radial nerve, they're innervated by the ulnar nerve. There are no intrinsic hand muscles that are innervated by the radial nerve. Cool? I made that point clear? Good. Anatomical snuff box, yeah, like the borders, yeah, you can learn them, sure. But what's really important, what do you actually find in it? So if you get a scaphoid fracture, it's gonna be tender over the anatomical snuff box. You can also feel your radial artery there, and you can also find the cephalic vein there. The end. Cool. This is where the big exam money is at. Brachial plexus. So unfortunately, you cannot avoid not learning the brachial plexus for the sake of fire. I know it's so fuck, everyone swears on it. But this is like the pinnacle of what underpins the upper limb neuro structures, so you can't really avoid it. That being said, however, with one exception, you probably actually don't have to learn all the minor branches like the lateral pectoral nerve and all the nerve to scapularis. Just learn the main 5 branches. That's the highest deal. Learn the association between the brachial plexus and the axillary artery, and also where they come from, because that's now relevant because you guys now technically have done the neck anatomy. I'll put the point in the post presentation slides, I forgot. But remember that brachial plexus emerges between your anterior scalene and middle scalene muscles. I think that was an exam question the year before us. So you could skip a year and come back to you guys. Right. So brachial plexus pathologies, you have the Klumpke paralysis and Erb's palsy, or the full name Erbduchen. I'm not gonna pronounce that. Right, palsy. Klumpke is like monkey. So Klumpke like hanging on a tree. Monkeys hanging on a tree. You pull off. If you try to hang off from the tree, you're gonna be feeling the tension here. So you pull away the lower border of the brachial plexus, lower part of the brachial plexus, I should say. So your C8 and T1 nerve roots, and it basically loses, you lose the C8 and T1 nerve root innervations. So, and also you can actually get Humerus syndrome of that, because T1, if you remember, is actually where your sympathetic nerves come from. T1 to L2, sympathetic nerve innervation. Right. Erb's palsy, this is a little bit easier because like, okay, so this is basically when someone grabs you by the head and tries to pull you away. C5 and C6 nerve roots are injured, so it's on top of the brachial plexus, unlike a Klumpke. And it presents as a really like pathognomonic presentation, which is medially rotated arm with extended and pronated forearm and flexed wrist like that. And you can't actually return your arm to a resting position because you've basically lost all the innervation in the opposing muscles. So that's the classical presentation. I don't know why that's not bolded. I'll bold it later. Right, and also the long thoracic nerve. This is probably something that everyone remembers. I'm gonna go through it quickly. C5, 6, 7 wings to heaven. You lose the serratus anterior muscle and you get the winging of the scapula. That being said, however, be careful in the exams that they may not necessarily just drop the term, this patient has the winging of scapula, what nerve has been impaired. They may actually describe what winging of scapula looks like, which is basically protracted and posteriorly dislocated scapula. So be careful on that. They don't necessarily drop the buzzwords anymore, unfortunately. Right, next one, axillary nerve. Cool, innervates the deltoid muscle. Sensory innervation, regimental patch area on top of the deltoid muscle. Where does it occur? So, okay, so as far as the nerve structures of the upper limb goes, in terms of exam, you have to know 3 things. 1, what nerve is it actually? 2, what does it innervate? And therefore, if you lose it, what kind of presentation are you actually going to have? And 3, where are you most commonly going to damage it? And hence, that's why I've basically made this presentation in this structure. So, what does it actually innervate? Motor, deltoid. So if you lose deltoid muscle, you're going to lose the remainder of the abduction past the first 30 degrees. What sensory innervation? Regimental patch area, right? When do you most commonly lose it? When you have a surgical neck fracture of the humerus or dislocate the humerus. Incorrect injection sites, yeah, sure. Right, and also it results in, yeah, I've already said it already. So inability to abduct the arm past the 30 degrees and also the sensory loss. Musculocutaneous nerve, it's got its name because muscular because it innervates the anterior compartment of the arm, and then cutaneous because it proceeds to innervate the lateral compartment of the forearm, lateral side of the forearm. It provides the cutaneous sensory innervation. So if you lose this nerve is kind of random. You can lose it really anywhere along the path. There isn't a really pathology associated with it. But if you do lose it somehow, then 1, you'll lose all the motor functions in the anterior forearm, so you can't flex, and also you lose all the sensory innervation of the lateral forearm. That's probably more important. Cool, radial nerve. What does it do? As I said again, anything that's posterior, it's innervated by the radial nerve. Sensory, as far as the sensory goes, it innervates the dorsal 3.5 digits of the hand. And how do you lose it? Well, if you get a mid-shaft fracture of the humerus, the radial nerve is running down the what's the word I'm looking for? Humeral shaft? No, radial groove. That's it. Radial groove along this, and which is most commonly damaged at the mid-shaft of the humerus. So if you get a fracture there, you lose the radial nerve. And because it innervates everything in the posterior, anything posterior does the extension of your upper limb, and therefore, if you lose radial nerve, you get the wrist drop, and also everything like sensation in the posterior side. Median nerve, you lose it at the cup. What it does, as I said before, is the main innervating nerve of the anterior forearm, and also the thin eminences, right? And innervates the palmar side of the lateral 3.5 digits. So if you lose the radial nerve, you lose the dorsal 3.5. If you lose the median nerve, you lose the medial 3.5. You still lose the lateral 3.5, but you lose it on the palmar side instead of the dorsal side. And you lose this nerve in carpal tunnel and also sometimes in medial supracondylar ridge. And if you lose this nerve, you get hand of Benedictus sign, you get wasting of the thin eminence because it innervates it, and also you lose sensation in where it's innervating it. Ulnar nerve, so it does the opposite of median nerve, kind of. So it basically innervates everything. So unlike the median and the radial nerve, which only innervates palmar side and dorsal side, respectively, ulnar nerve actually innervates everything. So palmar and dorsal side of the medial 1.5 digits, as far as the sensory goes. As far as the motor goes, there are only 2 muscles that innervate in the anterior forearm and basically everything else in the intrinsic hand. And the most common place to lose this nerve is in the medial epicondyle, but you can also lose it in the guidance canal. Cool. You get something called Froment's sign as well. So this is where you ask the patient to actually, can you hold this paper between your fingers, and then you try to pull it away. If the patient has lost the ulnar nerve, then they're gonna try to hold on to the paper by actually trying to flex the thumb instead of adducting the thumb, right? So that's called the positive Froment's sign. Ulnar claw versus the hand of benediction, it's really important to know the distinction. I'll just quickly go through it. So ulnar claw, it's in the name. It happens if you lose the ulnar nerve, and hand of benediction if you lose the median nerve. The main difference is that they present exactly the same, except ulnar claw is present at rest, where because it's inability to basically extend your medial 1.5 digits. Whereas the hand of benediction, it only happens when you actually ask the patient to make a fist for them. So this hand of benediction happens because you lose the ability to flex the lateral 3.5 digits. You can read that in your own time. And then there's also something called the ulnar paradox. So basically, the closer to the hand the ulnar injury is, the more severe your presentation of ulnar claw is. So the more function of upper limb you lose because your ulnar nerve was damaged more proximally, the less severe your ulnar claw presentation is going to be. That's got to do with the loss of flexor digitorum profundus, but you can read that in your own time. Right, sensory innervation of the upper limb. So myotomes and the nerve innervation and the dermatomal innervation. I'm not going to say anything about it because it's basically a picture. However, that being said, there were actually quite a few dermatomes questions, especially lower limb dermatomes, last year at the bias. So even though I'm not going to say anything about it because it's just memorize the picture, please do have a read at it again, and please know your dermatomes and the nerve innervations because they will probably come up. They really liked the question last year. There were like 2 or 3 questions or something. Cool. Myotomes, there's a table for you if you want to have a read at it. There you go. For all skills as well, helpful. Right, arteries. So you have the subclavian artery, which directly arises either from the aortic arch or the brachiocephalic trunk. Then it becomes the axillary artery after passing through the lateral border of the first rib. So know where the arteries are actually getting their name changes. So subclavian becomes the axillary after the first rib, lateral border of the first rib. Axillary becomes the brachial artery after passing through the lower border of the teres major muscle. I think I have a picture of that. Yeah, I do. Okay, cool. And brachial artery becomes branches into the radial and ulnar arteries after passing through the cubital fossa. And also know which of the radial artery and the ulnar artery is the major contributor of the palmar arches. So radial artery is the major contributor of the deep palmar arch, whereas the ulnar artery is the major contributor of the superficial palmar arch in the hand. Anyone lost? Good. There's a nice picture of it, but with brachial plexus in there. Veins of upper limb. So 3 superficial veins that you have to know about. You don't have to know about the deep veins because they just follow the mirroring corresponding arteries. So 3 superficial veins. Basilic vein, if you put yourself in the anatomical position, basilic vein is towards the base of your body, whereas cephalic vein, ceph means head, so it's closer towards the head, so it's towards the head, like it's on top of the upper limb, it's on the more lateral side, right? And also the median cubital vein, which basically connects the basilic and the cephalic vein in the cubital fossa. And you also have the deep veins of the upper limb, which you don't have to know every single individual name because there's just like names of the corresponding arteries, so it's like brachial vein, axillary vein, subclavian vein, radial vein, ulnar vein, right? they exist in the form of vena comitans, which are just basically a pair of like deep para-arterial intercommunicating veins. Right, and if that presentation wasn't short enough for you, here's a summary of basically everything that's gonna be on the exam in 3 slides. Yeah, that's all you have to know about the upper limb. Probably a lot less than actually what's written on there even. And that's it. There you go. That's all you have to know about the upper limbs. Done. Not going to take 2 hours to do that.
That's really short.
Yeah. We had a lower limb presentation last year for the revision.